Obesity is a complex multifactorial disease. It is one of the most neglected or less emphasized health problem. Its prevalence of overweight and obesity has doubled since last 2 decades. Nearly a third of the world population are now classified as overweight or obese. In India also, there are more than 135, nearly 150 million individuals who are affected by obesity. The prevalence of in India varies secondary to age, geographical location, and environment and socioeconomic status. It's the main medical and financial burden to the government, not only for the developing nations, but also to the developed nations. WHO defines WHO defines obesity as a condition of excessive fat accumulation in the body to the extent that health and well-being of an individual is adversely affected. The amount of body fat exceeds the normal physiological values. The limitations are physiologically normal amount depends on age and sex with a high variation among individuals. In children, a BMI of more than a BMI for age in the 85th percentile and less than 95th percentile is the go on the CDC core chart. Obesity in BMI more than age 95th percentile of the CDC core chart. Various modalities are there to measure the body fat. Different techniques like fat densitymeter, hydrometer, dual energy X-ray absorptiometer, chemical multi-compartment models, CT, MRI are used to check the body fat. Large-scale use that can predict the body fat percentage like skin fold thickness, impedance, bioelectrical impedance, BMI, waist circumference, and body adipose tissue index. The measurement of fat is also dependent on age and sex, and there are clearly defined cutoff points which are usually cannot be attained in a clinical scenario. It is limited in terms of accuracy, both portable and also practical use. And the body mass index, now measured as the standard which is used throughout the world, is the ratio of weight in kgs divided by height in meters squared. It is a good predictor for the overall health and nutritional status. As mentioned in the tablet, the underweight is less than a BMI of less than 18.5, and extremely obese individuals where the BMI is more than 40. Weight circumference in combination with BMI evaluates the health risk also. Waist to hip ratio is another modality to measure the fat percentage of in an individual. BMI is an estimate rather than an accurate measurement. The risk of discrimination against certain group and care may be denied to patients who may benefit. It fails to account for fitness. There is a wide variation of body adipose tissue in the same BMI. Obesity has become a global burden. It is extremely significant and an increasing public health challenge in both economically developed and developing regions. 33% of the world adult population are obese. More than 40 million children under the age of 5 years are overweight, and estimated that by the end of 2030, up to 60% could either become overweight or obese. The prevalence of obesity or overweight is rising in the developing country, particularly in the urban setting. It is a double burden in developing countries where they have to deal continuously with the problems of infectious diseases, undernutrition in children, experiencing a rapid upsurge in non-communicable disease factors such as obesity and overweight. It is more vulnerable to inadequate prenatal, infant, and young child nutrition, same time exposed to high fat, high sugar, high salt, energy dense, micronutrient, poor foods, which tend to be of lower cost. Urbanization, mechanization has increased the rate of the uh, people sitting and viewing television, and increased pressure to perform scholastically have led to the sharp decline in physical activities. Basically, sedentary life is causing more problem in urban world. Interaction of the above factors with change in dietary patterns have increased in childhood obesity and metabolic syndrome. The complex interaction of genetic factors, including variation in DNA sequence, epigenetic factors, in vitro environment, behavior, lifestyle, ethnic variabilities, increase in prevalence of obesity and chronic diseases related to obesity. Coming to prevalence in India, India is in a transitional state of undernutrition due to poverty and obesity due to industrialization and rapid urbanization. More than 135 million individuals are affected by obesity. The National Family Health Survey, the Survey 4, which was done in 2016, has reported that socioeconomically backward states have low rate of prevalence as compared to the higher socioeconomic status in India. And these are the various Indian programs or studies with respect to the overweight or obesity in our country. Obesity is also prevalent due to discrimination shown to particular individual. Overweight with obese individuals are vulnerable to negative societal attitudes, stigma, and prejudice. There is discrimination at the employment area and also discrimination in the healthcare, wherein the authority or people who are involved in health sectors will usually feel that the any amount of provision to the obese individuals of the healthcare budget is waste or useless. And also these patients are discriminated by unsolicited advice to lose weight by healthcare workers, causing embarrassment to the individuals. The discrimination leads to psychological and physical health. Experimental research has shown that providing individuals with information emphasizing personal responsibility for obesity increases negative stereotype towards obese persons, whereas proper information highlighting the complex etiology, that is biological and genetical contributors of obesity, improves the attitude and reduces the stereotype. The prevalence is varying from rural to urban state-wise. The main factors are geographical condition, lifestyle, and dietary patterns. High socioeconomic status, sedentary lifestyle, high calorie food intake. Prevalence is rapidly sprouting due to sedentary lifestyle and consumption of high calorie food. Obesity results in various health problems which have direct link to the cardiovascular diseases. So to curtail this problem, public awareness programs like education of obesity, about obesity and its consequences, the health agencies should promote healthy dietary habits and active lifestyles, teach people about the bad effects of the high calorie foods, the prevailing societal and media message that reinforces blame on obese persons need to be replaced with positive messages. Supporting individuals with adaptive ways to cope with weight stigma can facilitate weight loss outcomes. This is the epidemiology of this concern, obesity.
Right, Mahesh. See,
Yeah.
now it's well presented and all the facts have come out. There is a national NHFS 5, which has come in
Okay.
2019-20, I think. Hmm? So there
Okay.
also the statistics are all given differently.
Okay,
So
sir.
that is the latest which we can refer to. NHFS 4 is 2016, I think.
2016, I went through that. Uh,
Right, right.
I
So
couldn't get this.
nine-
I'll check it out, sir. Analysis 5.
1920 is also there.
Okay, sir.
So even as per the world statistics now, India is the third most obese country.
Okay, sir.
After US and China, India is the third country. The problem with India is there is almost equal number of undernutrition and also the overnutrition. So basically it's a
Yes.
malnutrition problem where some people are getting excessive calories and getting into obesity and developing problems, and others who are deprived of nutrition and going under nutrition and they are developing other. So we see the two extremities.
Yes, sir.
extremes, sorry, of the malnutrition problem.
Okay, sir.
Okay, continue, Mahesh.
So now we'll discuss the second lecture of today, that is overview. And am I audible, sir? Hello.
Yes, yes, audible, Mahesh.
Okay, sir. We're going to talk about the overview and evolution of bariatric surgery. And I have particularly put this slide here. This every year, WHO celebrates or commemorates the World Obesity Day on March 4th. And this year, every year they have got slogans. And this year, the slogan was "Everybody needs everybody" in view of the COVID pandemic, and this has come out very well. As mentioned earlier, obesity is a complex multifactorial disease. It is one of the most neglected health problem. Nearly a third of the world population is now classified as overweight. In India, more than 135 million individuals are affected. It is a main medical and financial burden. The WHO defines obesity as a condition of excessive fat accumulation in the body to the extent that health and well-being are adversely affected. Amount of body fat exceeds normal physiological values, that is caused as obese. This slide already I have presented. And how to calculate BMI is also mentioned here with the ratio of weight in kg divided by height in meter squares. The extremities are underweight is less than 18.5 BMI. Extremely obese is more than 40 BMI. Waist circumference and various other modalities of BMI measurements or body fat measurements, as discussed earlier. It's a global burden, extremely significant and increasing public health challenge in both economically developed and developing countries. More than 40 million children under the age of 5 are overweight. And as I mentioned earlier, by 2030, up to 60% could be either overweight or obese. With various reasons, as mentioned earlier, exposed to high fat, high sugar, high salt, energy dense, micronutrient poor foods, which tends to be available in lower cost, urbanization, mechanization, higher rate of television viewing, and increased pressure to perform scholastically have led to the sharp decline in physical activities. In India, more than 135 million individuals are affected by obesity. Obesity results in various health problems which have direct effect on cardiovascular system. And in India, geographically, there is variations as mentioned here. Public awareness programs and health agencies should promote positive notes about obesity. Coming to the history of evolution of obesity, late in 19th century, obesity became a recognized an aesthetic issue, and in 20th century it is recognized as a health problem. As early as earlier in there was this in Spain, 10th century, second King Leon, Jewish doctor, Huston bin performed a suturing the king's lip and advising him liquid diet through a straw. But this was unsuccessful because the king was able to consume high calorie liquids, and he was like becoming obese. Hence, this method was discontinued, and an important concept in bariatric management recognized, that is surgical management. The initial era, majority of the nutrient absorption occurs in the small intestine. First region of the GAT considered for surgical revision to produce weight loss began with observation that surgically shortened small intestine and secondary malabsorption will lead to a sustained weight loss. In 1954, Carmen and et al. reported a resection of the control length of small intestine in dogs, resulting in impaired fat absorption and consequent weight loss. These research were in the background of following World War II. There were a lot of young scientists and doctors, and they were allowed to do a lot of experimental studies in animal. And Carman et al. And some of the fellow doctors joined together in practicing or researching the methods of surgery to curtail the obesity. So this was one of the small procedure they did in the dogs, and those patients who lost a portion of the small intestine for various reasons lost weight despite increased calorie. A significant decrease in functional absorptive length of small intestine can result in impaired absorption of nutrients and dumping syndrome associated with certain food intake. John Liner set about transposition segment of small intestine, understanding the physiological role of jejunum in metabolism. There has been an instance um, or a study or a procedure described by Liner. Liner performed a revision of a primary bariatric procedure in 1981 on a woman, and this woman survived till age of 61 when she died due to cardiac event. Although she was still heavy, but she had not regained her original severely obese state. And this was the beginning of the obesity surgery, wherein the scientists and doctors started looking into uh, sh- using the principle of shortening the length of the intestine, helping to reduce the weight. Next, Penny Divine and Commons, who was a pathologist, they did a surgery in morbid obesity, which is like an end-to-side echinocholic shunt in 10 patients. The protocol included re-establishment of continuity with optimum weight when the optimum weight was achieved. Penny termed the word morbid in along with obesity just to encourage the insurance companies to pay for these patients. And the results were there was weight loss in each of the patients. One patient died 6 months following pulmonary embolism. Six patients in whom the continuity was restored all regained the previous obesity state. Three patients reversed it to end-to-side jejunal shunt. One of these in which substantial amount of jejunum was placed back in continuity with the experienced weight regain. Reasonable amount of jejunum and small portion of ileum were left in continuity with the ingested food. Weight loss could be maintained. Interesting and best studies side effect development of the all these studies developed a side effect and patient developed some patient developed liver failure, and the findings of this liver failure were close to the liver failure in alcoholics. And also there was bacterial overgrowth of gram negatives and anaerobic bacteria in the excluded limb, along with morphological changes in the intestinal wall, which played a role, and this was termed as enterohepatic syndrome. So various procedures were tried, and in 1963 again, Payne and et al. First surgical procedure, which was purely malabsorptive. They performed a end-to-side anastomosis with jejunum to the proximal transverse colon, jejunum to proximal ascending colon. Majority of the weight loss in the first post-operative year was recognized. There was decreased absorption of fat and decreased serum cholesterol and lipoproteins. The drawbacks were there was fatty, foul-smelling stools, significant diarrhea, and various anal complications. And there was poor absorption of vitamin B12, A, and D, and also minerals like magnesium, potassium, and calcium was noted. The Digino-ileal bypass in 1969, Payne and Devine performed another procedure, which was an end-to-side anastomosis. In 1976, Scott Jr. and et al. They performed a end-to-end anastomosis of jejunum to the ileum, and where the bypassed long segment of transverse or sigmoid colon, there was a better weight loss was maintained, and because of loss of reflux of nutrients into the bypassed small intestine. The drawbacks were, as I mentioned earlier, anaerobic bacterial overgrowth in the long excluded blind loop termed as bypass enteritis resulted in abdominal bloating or distension and lactose intolerance, contributing to foul-smelling flatus and stool, affecting joints, multiple joints, leading to and also hepatic failure, absorption of bacterial toxins. Anal problems like anal excoriation, hemorrhoids, continuous diarrhea, ulcers were also found. There were renal stones and leading to renal failure, alteration in luminal absorption of fatty acids and calcium oxalates, loss of potassium, magnesium, calcium, and vitamins, and protein deficiency secondary to neuropathy, bone demineralization, myalgia, and peripheral weaknesses and edema were also found in these kind of patients. The mortality rate was up to 4% within the first 2 years, mainly due to liver failure following the procedure. Mason et al. In 1970 came with a novel procedure and developed a horizontal gastroplasty technique, stapled the stomach transversely towards the greatest curvature, leaving a small orifice for the communication between the uh, proximal and distal stomach. Later modified by several surgeons to various configurations, wherein they increase the orifice or the opening between the proximal and distal stomach, leading which were termed as horizontal gastroplasty with luganostomy, horizontal gastroplasty with Roux-en-Y bypass. Mason and Law together in 1980 performed the vertical banded gastroplasty, which became slightly popular during those days. The stomach was vertically stapled but not divided, creating a small 30 centimeter gastric pouch reinforced with a mesh strip or a elastic ring. Adjustable gastric banding. Later, Los L. Guzman invented the first elastic ring with a small balloon embedded on the inner aspect of the ring that could be accessed from a subcutaneously placed reservoir, allowed the calibration of the outflow of the lumen. There was excess weight loss causing significant food restriction in early satiety. Patient would modify their food intake by consuming high calorie liquid with resultant weight regain. The drawbacks of this procedure were breakdown of the vertical staple line, allowing recanalization of proximal stomach to the restricted portion, bezoformation, vomiting, outlet obstruction and stenosis, staple line dehiscence, post-surgical leak, reflux, and megaesophagus were found in this procedure. The patients with original gastroplasty are now frequently revised using other bariatric procedures. Later, Mason in 1967 developed gastric bypass procedure by surgically isolating a portion of the stomach along with a retrocolic loop of gastrojejunostomy. Initially performed in an undivided fashion whereby non-cutting staplers were used, division with staple line without physical separation. Small pouch permanently restricted the food intake, allowed more sustained weight loss up to 50%. Again, the drawbacks of this procedure were dumping syndrome, breakdown of the suture of staple line, marginal ulcers at the junction, reflux of bile, and also leaks were found, and vitamin and mineral as well as protein deficiency were also found post this procedure. A biliopancreatic diversion, failing to obtain maximum sustainable loss, restrictive food limitation in early satiety, malabsorptive, decreased nutritional absorption. The earliest biliopancreatic diversion was Scopinaro et al. In 1979, a modification of ileal bypass, 200 to 250 uh, 200 to 50 ml horizontal gastric pouch with distal gastrectomy with closure of the duodenal stump plus gastroenterostomy with 250 centimeter roux limb, biliopancreatic limb, anastomo to the roux limb, 50 centimeter proximal to the ileocecal valve, 70% long-term weight loss in more than 90% patients were achieved. It eliminates bypass enteritis and related hepatic failure. It decreases incidence of frequent diarrhea, renal calculi, marginal ulcers, protein malnutrition, vitamin electrolyte deficiency. The drawbacks were frequent voluminous stools and malodorous stools, increased risk of deficiency of calcium and fat-soluble vitamin and proteins, post-gastrectomy syndrome leading to marginal ulcers and dumping. The classical biliopancreatic diversion with duodenal switch with pylorus sparing procedure by Markey in 1993. Due to the high incidence of post-gastrectomy syndrome, greater curvature of the stomach is resected, leaving a tube-like remnant while preserving the pylorus. The enteric limb, 250 centimeter roux limb, anastomosed to the post-pyloric duodenum. Long duodenopancreatic limb is anastomosed to the roux limb, 50 centimeters proximal to the ileocecal valve. reserved for super obese people with a BMI of more than 55. Also a revision for other failed bariatric procedures. Longer alimentary and biliary limb with shorter common channel can result in greater weight loss over the first, second 2 years postoperatively. Decreased absorption of nutrients in the common channel, which receives food mixed with gastric, biliary, and pancreatic fluids from both alimentary as well as biliary limb. The drawbacks are, with the usual, with all the most of the procedures like calcium, iron, magnesium, vitamin, protein deficiency, malodorous stools and flatus, risk of anatomic complications, multiple anastomosis, bowel obstruction, ventral and internal herniation, anastomotic leak, fistula formations, and abscess formations were also found in these procedures. Next comes the Magenstrasse and Mill procedure. Johnston, 1987, performed the first procedure. The Magenstrasse refers to the thin tube created from the lesser curvature. The Mill refers to the antrum, created using a circular staplers to create a defect in the antrum, then creating a narrow tube along the lesser curvature, initially over a 40 French, and now it has changed to a lesser French to optimize the weight loss. Subsequently improved by resecting the greater curvature. The result was sleeve gastrectomy, previously performed as a part of restrictive component of the duodenal switch. So then the era of sleeve gastrectomy or the sleeve gastrectomy came into picture. Initially used as a two-step procedure in the high-risk BMI more than 60 to the patients. Close follow-up reveals substantial weight loss and resolution of comorbidities with sleeve gastrectomy alone. Indication of laparoscopic sleeve as a standalone procedure were published in 2000 as early as 2008, and it has become a standard procedure now. Popularity grew due to perceived simplicity of the procedure and adequate resolution of comorbidities. So apart from these procedures, there are other procedures by which the gut recognized as a hormone, where the metabolic or the GI tract was changed. As better understanding of the gut peptides emerged, procedures were developed to produce hormonally induced weight loss. One of them is the ileal interposition, targeting the gut neurohormonal activity. Mason, 1999, interposed helium to a position in the proximal jejunum and produced weight loss. Method was a 170 to 200 centimeter long portion of ileum was isolated, leaving 30 centimeter of distal ileum. This segment was relocated 50 centimeter distal to the ligament of treats, utilizing two jejunal-ileal anastomosis. Bowel continuity was restored with a third jejunal ileal anastomosis. Multiple peptide studies surely play a role in food intake and satiety. Through this path of investigation, feature innovation will improve the safety and effectiveness of this procedure. This is a picture of the ileal interposition as mentioned. In 1990s, pivotal techniques revolutionized in general surgery began to explore laparoscopic approach. The first laparoscopic gastric bypass, Whitgrove and Clark, performed in October 1993 using a retropolyclinic with circular stapless anastomosis for the gastrojejunectomy. Initially, technical constraints made the procedure very difficult, but as experience grew, popularity increased rapidly. The era of invasive surgery revolutionized the surgical management of obesity. The rate of complications reduced, the operative mortality reduced from 1 to 0.2%. Hospital stays also changed from 3 to 5 days to 2 days. Reduced impairment of pulmonary function tests, less intraoperative blood loss, shortened hospital stay, decreased rate of wound infection and incisional hernias were rare, decreased the cost, routinely returned to work in less than 2 weeks. These were the advantage of the minimally invasive obesity surgery. The first successful laparoscopic banding procedure was published in 1993 by laparoscopic placement of non-adjustable gastric band in a 16-year-old female. The year prior was also performed. Dalachu diagnosed, designed an adjustable gastric band which could be placed using the laparoscopic technique. O'Brien from Australia published a review of laparoscopic adjustable gastric bands that showed durable weight loss on 47% excess body weight. The first laparoscopic uh, duodenal switch was performed by Ren and Gagner in 1999, associated with larger weight loss, reserved for the patients with BMI more than 60, technically difficult and concerns of nutrition deficiency not widely adopted. The first robotically assisted duodenal switch was performed in 2000 by a totally intracorporeal approach. The operative mortality is approximately 1%, slightly higher in laparoscopic performed comparably 2.5%. To conclude, surgical management of obesity has evolved over the past 5 decades. Popular treatment methods for morbidly obese patients, acceptable risk-benefit ratio, and produces amelioration or control of many of the diseases associated with serious obesity. Minimally invasive approach has contributed remarkable to improvement of risk-benefit ratio, reducing the mortality rate to less than 1%. Although much remains to be understood, metabolic or bariatric surgery has emerged from shadows of charlatanism into mainstream of general surgery. As mentioned in the books, the baby was not thrown out with the bathwater and has emerged on the surgical stage as a vibrant, healthy adolescent.
Right, Mahesh. It was a good presentation.
Yeah.
2-3 things about there is a approximate ideal body weight calculator that's called the Brocas index.
Yes, sir.
The Brocas index is that whatever is the height of the patient, so minus 100. If the patient's weight is about 185 centimeters, you minus 100 in that, which is a constant. So body weight should be around 85 kgs,
Ideal
like
body
that.
weight. Okay, sir.
So this ideal body weight. So this is not absolute or anything. You can get a rough estimate of that quickly when you're seeing the patient in the OPD or anything. From there, you can take up the body mass index and all.
Okay.
So evolution of bariatric surgery you have brought out very well. Whether I missed or not, I don't know. Did you mention about the vertical banded gastroplasty?
Yes, sir. With the picture I have mentioned.
Okay.
Yes, sir.
Horizontal you had shown.
Yes, sir.
So vertical banded gastroplasty was one which was popular earlier, which has now gone into dustbin. If you see the evolution, the weight loss surgeries have gone from the distal part of the gut now to the
Stomach.
proximal part of the gut. And earlier all were open surgeries, which has now gone into totally laparoscopic or the robotic way. That's a big revolution. That's why the complications reduced and the patient's acceptance improved, and uh, the popularity of bariatric surgery as a weight loss management tool has definitely improved. Another procedure, whether you mentioned, is the one anastomotic gastric bypass or mini gastric bypass. That's also now well accepted and quite popular.
Yes, sir.
That's another procedure which is in the armamentarium of the bariatric surgeons. So, all right, I think that's a good presentation. Anything else you have comments?
I actually wanted to check the evolution of obesity surgery in India, but there were no papers or the material which I could get hold on. And there was one paper along with you and Dr. Bhaskar presented about it. But even in that, exactly the history of how it started, I couldn't
Right,
get it. We have like how we are doing, but who started first case or that I couldn't get it, sir. Actually.
right. Actually, in India, Professor Chaube and group, Pradeep Chaube and group Delhi, they did the first gastric banding, and
Okay, sir.
from there it took off adjustable gastric banding, and from there it started. I think the row and way gastric bypass also from their group only first case, I think.
Okay, sir.
Okay, thank you, Mahesh.
Thank you, sir.